Okay, welcome to the microphone, Dr. Patty Thorpe. We're going to talk about ankle and calf edema after RFA. What to do now? And I know we've all had this patient.
Thank you very much. Thanks. This topic and this talk sort of arose from the number of calls I've had from, and I don't mean to malign you, but from cardiologists who do RFA, start doing RFA, and they do that, and then they call me and say, well, this lady, we did this RFA, and it seemed to be good, but her leg still bothers her. And the question I ask them oftentimes is, well, did you look at the whole leg? Did you look at the deep system? No, we were just doing the varicose vein stuff. So this is a problem I have with physicians who want to do venous work, and they don't understand the anatomy, the venous anatomy of the lower extremity or the arm. They just want to do a small portion of RFA and make the money from that, and they don't have any sense of what possibly could go wrong. And I always taught the residents, well, you have to ask yourself, what's the worst possible thing that could happen here? And you have to be ready for that. So here's a picture of a patient in this month. This is what her leg looks now, but I'll show you what it looked like before and when she was called. I think that's backwards. Here is a picture of her legs when she was presented to me. This is, you can see her right leg is larger and her left leg, but she had the RFA ablation on the left leg. And you can see that she has some edema and redness there in her left ankle area. Well, the best thing you can have on your team and amongst yourselves is a good tech, a good ultrasound tech, a dedicated ultrasound tech, man or a woman, and because they're my best friend for any of the procedures that we do, particularly the RFA and the deep venous system. And I have come to learn in Omaha and Phoenix and Iowa City that I don't trust hardly anyone else's ultrasound except my tech's ultrasound, because there are so many people who do ultrasound exams that really aren't very well trained. So you have to know who you're dealing with, of course, but the certification of ultrasound labs hasn't really been universal. This is what you're looking for. When you do an RFA, you should take the time to look at the iliac vein. If you ever see an iliac vein flat line there in the groin, that's a red flag. And it's a red flag because up in the left iliac, or common iliac, or higher above, there is a high velocity because of a stenosis. Because the slides I have for how many people have May-Thurner in the United States and the world is a lot. A third of the population is born with an iliac compression. That's just the way we're made. And it has nothing to do with male or female. The reason why we think May-Thurner is maybe more prevalent with female is because there are more risk factors for thrombosis, like pregnancy and use of hormones. But there are a lot of men who get May-Thurner compression syndrome with thrombosis when they take testosterone. Hormones are a risk factor. Steroids are a risk factor. So if you haven't looked at the iliac vein waveform when you think you're going to do an RFA ablation, it's foolish because you could make the patient worse. Now, this is the ulcer that she had when she had her RFA and came back to see me. And that is her iliac, and you can see that there's a stenosis in the common iliac. You can see that she has a reference of flow into their internal iliac, across to the other side. This is the IVUS measuring the iliac, and you can see how narrow it was, side to side. Very wide front, 23.5, width, and front to back, sorry, it was 5 millimeters. So here's the stent we put in, and this was a number of years ago that we put a stent in this woman. There's a post-stent now, and there's the stent. Now, there is the ulcer that manifests within maybe the year after her stent was placed. Not after her stent was, excuse me, after she had her RFA ablation. And that's why this, the cardiologist sent her to me. And I'm sorry, we seem to have lost the dates on these, but first one was in 2014, and the second one is in 2024. You can see she presents with the residual of these scars. And this is 2014, and this is now later, 2024. So the scars are still there. Her SFA is ablated, and she did get a stent. And I made this brief because there's a really strong message here. If you're going to do RF ablation, you have to consider the deep system too. It's good sometimes that the deep system isn't perfect, that the flow will go into the deep system, but you have to make sure that you're not taking out the greater saphenous vein in a patient who has a significant compromise of their iliac system. So that's my message for this. Thank you.
Yeah, if I could add a quick point. Every patient that you get the ultrasound, you must make sure that the deep is open. Sometimes you'll see varicosities, but actually they're collaterals because the deep system is secluded or has a chronic occlusion. And I've seen enough where they've ablated whatever was in the superficial and actually made things dramatically worse.